extensive contributions place her in a prominent and impactful position. Please, Dr. Kristijana.
Thank you very much for the kind introduction, and thank you very much also for inviting me to visit your wonderful historic country and give me the opportunity to speak about maybe some principles we think are important in successful screening. Let's start with a short introduction. I'm coming from Slovenia. It's a very tiny compared with Egypt, a country in the middle of Europe. We have altogether 2 million people. And Dora is the name of our national breast cancer screening program, which is one of the most successful young screening programs in Europe, organized very much according to European quality guidelines. We screen women 50 to 69 every 2 years. With digital mammography, without clinical exam. Every woman gets an invitation letter to her home address. They don't need to pay anything. It's covered by the insurance company. And all mammograms are double read by 2 radiologists independently. And our screening program is completely separated from diagnostic centers. And we started in 2008, and in 10 years we covered the whole country. And now we are a successful educational center for the countries who are looking for an advice for screening, to implement screening. We also very successfully collaborate with IAEA and are part of different EU projects. We screened approximately 110,000 women annually, and our participation rate is one of the highest in Europe. And last year it was 78% of women attend the screening. 3% are recalled for assessment, and according to our own results now, 70% of cancers, detected cancers, are in stage 0 and 1. That means limited to the breast. And now I would like to, we all know that the main goal of screening program is to detect clinically non-palpable breast cancers in asymptomatic women, because such small cancers like with the arrow, they are probably limited to the breast, and they have much better chances to cure than the cancer on the left, which is probably metastatic. And by finding small cancers, you can lower the mortality in the populations, screened population, for 30% or even more. And according to our experience, we think that 2 areas are important for a successful screening. First is high quality requirements, not only for the staff involved, like radiologists, radiographers, surgeons, pathologists, but also high technical equipment, and what is important, organization of an efficient clinical path from mammography till the diagnosis of cancer and treatment. And why there is difference between diagnostic centers and screening. And in diagnostic centers, all women are symptomatic, and most of the cancers are palpable. And on the other hand, in screening, we have non-palpable breast cancers, most of them. So clinical exam is very important in diagnostic centers, but not so in screening, and we don't have it. The other difference is that tumors in diagnostic centers are palpable, so they are larger, and there are not many palpable DCIS. And on the other hand, in screening, according to our results, more than 40% of breast cancers are 1 centimeter or less, and 15 to 20% of DCIS. And for small tumors, we know that they are difficult to detect. They are of non-specific look. So they need more experience, more educated radiologists to detect them. So compared with the diagnostic larger tumors. The third difference is operational palpable tumors, of course, are difficult, but not as difficult as operation of non-palpable tumors, which have to be localized first and then operated. So we need a more experienced team of surgeons and radiologists in screening. Symptomatic women are not the same than asymptomatic women. They have different pattern of behavior. In diagnostic centers, the women come because they feel a tumor. They are afraid. They want an examination. They are scared of cancer. And they are prepared to accept everything. Long waiting for the examination, unfriendliness of the staff, long waiting for the results, not enough information. But on the other hand, in screening, we have healthy women. They don't feel sick. They have no health problems. And they come only because we invited them. And believe me, they are not prepared to accept all these things I said before. And what is the end results then? These women will wait, despite of bad experience. But these women will never come again when you invite them. And if we know that screening can be successful only if more than 70% of women attend, so we understand that we have to create a program friendly to women's emotions if we want them to attend. So, on the left side, we have mostly, in screening, we have mostly healthy women. If we want, on the other side, to have high attendance rate, now we understand that we have to organize our screening according to women's emotions, that they are satisfied with us, that they don't need to wait long, they have only friendly staff, that they have very quick results, and they get assessment quick and also the operations, and they have enough information. Then they will be satisfied and they will come again and again. And the other thing is small cancers. We know that we detect small cancers in screening, and if we want to keep high standards of our process, screening process, we have to give additional effort to educate staff, especially radiologists, radiographers, surgeons, and pathologists. And we have to implement regular quality control of this stuff, and the organization must be efficient according to quality guidelines. And this is my last slide. Now I would like only to summarize what I said, that screening has two sides, advantages but also disadvantages. And in which direction the weighing scale will move depends on how much quality you implement into screening. Because this is the fact that detection of small cancer is the main advantage of screening. And then consequently we have less surgeries, we have less systemic therapies, less lost working hours, more effective treatment, and at the end we have reduction of breast cancer mortality. But on the other hand, if we don't have certain quality rules in screening, the scale can go to the side of disadvantages. If we have bad quality technical equipment and we don't maintain it regularly, then we can miss small microcalcifications and we will miss DCIS. If our radiographers are not trained enough, they will have bad positioning, they will miss a cancer on a mammogram. If the radiologists are not enough experienced, they will not detect enough breast cancers. And the consequence will be more missed cancers, and they will be detected later as interval cancer when the treatment will be much more expensive. And the other thing is unnecessary recalls. We will recall too many women unnecessarily. We will do the diagnostic. It will cost money, and the women will lose faith in you, in your knowledge. So they will not come again. You will have low attendance rate. And at the end of this, you will have much higher costs, and you will have much smaller reduction in mortality than you would like to have. Thank you. Thank you.
Thank you very much, Kristijana. I'd also like to